I don't like grading it any more than you like having it graded. It is a necessary evil. You cannot get into your programs with us just chit-chatting, though. Okay, so things that you need to know. Your test is on Monday. What does it cover? Cardiovascular and endocrine. That's it. Okay? It's a lot, though. Okay, so what I want to finish talking about is the last of the hormones. Where we were last time is we were talking about type 1 diabetes. Yeah? And now we need to talk about type 2 diabetes. But before that, remind me, type 1 diabetes is what? What's the problem? No, not insensitivity. Type 1. Hyposecretion of insulin. Exactly. You got it. Okay. So type 1 diabetes is a hyposecretion of insulin. It is generally a combination of genetic / autoimmune. Yeah? You didn't give it to yourself. Type 2 diabetes is what we were going to talk about. It's going to have a lot of the same symptoms: diabetic neuropathy, problems with wound healing, cardiovascular problems, kidney failure, all of those kinds of things can happen. But in addition, it usually has obesity. Not always, but usually has obesity. So I went and did some reading from the CDC last night. What do you guys think as far as percentages? Which type of diabetes is most prevalent? 2. And by what percentage? What do you think? It is. What percent do you think it accounts for in the United States specifically? 90 to 95% of diabetics in the United States are type 2, which is interesting because, of course, it is preventable. Yes, type 2 diabetes is preventable. And there are certain population groups that have a greater predisposition to type 2 diabetes. These are American Indians or American natives. My father was Blackfoot Indian, so I could go into that population. Black non-Hispanic has a relatively high proportion. White non-Hispanic is here. But we are still, white non-Hispanics don't feel safe because we are still the highest proportion of type 2 diabetes in the Western world. There are a couple of like second world countries that have a greater percentage. And it's been going up precipitously since 1980. Anybody have any prediction as to why that might be true since 1980? What? Yeah, physical activity has decreased. And what about prepared foods? Yeah, prepared foods have lots and lots of sugar, and we've been eating far, far more prepared foods as time goes on. So this is interesting. It's also something of a public health crisis because diabetes affects all of your body systems. It's incredibly expensive for this country to treat all of these type 2 diabetics. Incredibly expensive. So we'll talk about that in just a second too. Okay, so the problem with type 2 diabetes develops in a way that we've already discovered. So I want you to imagine me where I came from in Texas, right? Texas is famous, by the way, the whole South, and there are even worse parts than Texas, is famous for diabetes. Look, this is the diabetes prevalence in the United States. Red is bad. So look where I came from. Pretty darn bad. Colorado looks like it's doing super well. So New Zealand's really good too, by the way. They have a super low incidence of diabetes. So let's tell a little bit of a story that might lead to understanding how this occurs, especially in the American South. If you have a combination of high levels of processed sugary foods, especially sodas, because sodas are 0 nutrients, 0 fiber, right? But lots and lots of sugar. And if you have that in combination with low levels of activity, because I didn't explain this to you guys before, but your skeletal muscle actually takes up glucose by an insulin-independent mechanism when you exercise. So exercise is a really good mechanism to control blood sugar, yeah, even in the absence of insulin. So the American South, high levels of sugar consumption in prepared foods and low levels of activity. And so what's going to happen is if you give yourself a decade or 2 decades or however long, what that can lead to is high levels of sugar will cause high levels of insulin release, right? Yeah? But then it's trying to bring down your sugar, but then you drink another Dr. Pepper, right? High levels of sugar, high levels of insulin release, right? But you don't just do that one day or 5 days, or you don't just have a bender in which you're depressed and you decide to eat ice cream every damn day for 2 weeks. You do this for decades, right? And then what happens over time is that chronically high levels of insulin will start to do what to your receptors? Downregulate your receptors. And so it will lead to what we call a hypo responsiveness problem. Hypo responsiveness, right? So the problem is really that your insulin receptors become insensitive to normal levels of insulin. And that means whenever you're not drinking a Dr. Pepper, your sugar levels are going to boom, right? And then crash, and then boom, and then crash, and then boom, and then crash. And you get all of the same levels of damage in the tissues. But in addition to that, you'll probably also have the problem of obesity associated with it. And the obesity is predisposed to be in the abdomen, okay? So that has its own set of problems. I'm not saying that everybody who's type 2 diabetic is obese, because you can have a really high metabolism and you won't be obese, right? But a lot of people who have type 2 diabetes are obese. Okay, so that problem, type 2 diabetes, is classified as a hypo responsiveness. And I think the number was 74 million people in the United States are diagnosed with type 2 diabetes, but then there are far more who are pre-diabetic. They're in the resistant phase, but not yet in the diabetic phase. And then you get all of the health treatments associated with type 2 diabetes as well, cardiovascular abnormalities and kidney abnormalities and all of those things that are associated with type 2 diabetes. Now, of course, the interesting thing about this, and we need to reinforce it, is that this is preventable. This is something that we know how it occurs. It used to be called adult onset diabetes, but we as Americans like to do things first, so we have given it to our children as young as 7. We have children in the United States with type 2 diabetes as young as 7. But it is because of what we feed our children. They eat exactly what you feed them, right? Now, could they have a genetic predisposition? Totally. So I have a genetic predisposition to smoking-related cancers. I totally do. My mom died of a smoking-related cancer. My dad died of a complication related to smoking. So I have a predisposition to that. But I'm not going to get it. Why? Because I don't smoke. Exactly. So you can have a familial predisposition to type 2 diabetes, far more common if you're Native American, or if you're Hispanic, or if you're African American. But you don't have to get type 2 diabetes because you don't have to have high levels of sugar consumption and low levels of exercise, right? So you need that environmental trigger, and I'm not going to do that, so I won't get type 2 diabetes, right? So this is type 2 diabetes mellitus has become a public health issue. And I brought this up in the last class, and we can argue about it if you want at some point in the future. But do you know how in Utah and in many states they have what they call sin taxes? A sin tax is a tax on something that you consider non-essential, yes? Like alcohol and cigarettes. And you can use the tax to mitigate the effects of what you are taking in. So Utah, of course, has high levels of alcohol tax and high levels of cigarette tax. Well, I would propose that far more expensive than alcohol and cigarettes to the public health are processed sugary foods. And nobody will ever elect me, but if I ran ever, I would propose a sugary processed food tax in which those became far more expensive because they are causing public health issues that are even more expensive than the public health issues related to alcohol and cigarettes. Go ahead.
There are 2 comprehensive long-term studies that just finished in Europe that both classify diet as the #1 health cost.
The #1 health cost, yeah. But it'll be interesting because nobody will want to talk about that one. California, by the way, did put taxes on like you can't have big sugary drinks, and there are like taxes on really sugary things. It will be an interesting conversation for us to have in the future. But considering we can't even agree to like ban assault rifles, I don't know how sugar is going to go. But I'm going to keep talking about it anyway. Okay, so type 2 diabetes mellitus. I want you to make sure that you know the difference between those and you know the symptoms, even if you have to go read your textbook. I know that never happens. Okay, so by the way, the other hormone that comes from the pancreas is somatostatin. I don't ask you much detail about this one. I'm going to just tell you that somatostatin is different than the somatostatin that comes from the hypothalamus. The PIH doesn't have the same function. PIH, remember, doesn't go into the bloodstream in very high amounts anyway because it's just right there in the portal vessel. This one's same chemical used for a different reason. I'm going to oversimplify its function. What it primarily does is makes the pancreas sensitive to the feedback loops for insulin and glucagon to know when to stop secreting each. So it basically just makes it responsive to know when to stop. Okay, so chemical class of hormones, all of those pancreatic hormones are peptides. Okay, so now we are going to move to your gonads. Not yours, but the gonads. Can't talk about your gonads without violating Title IX, right? But we can talk about gonads in general, the universal gonad. We're talking about the universal gonad. All right, you ready? So oh, hold on, just a second. Oh, there we go. Okay, so the universal gonad functionality. So first we are going to do the testes, okay? So the testes, I don't know what you guys learned about testes function and structure and anatomy. Sometimes people do a lot of anatomical stuff on the reproductive system. I do, but sometimes people don't. Okay, testes have at least two functions. The two big ones are, of course, to do spermatogenesis and to produce and secrete androgens. Yeah? So as far as the functionality and the structure of that goes, do you guys remember that the spermatogenesis happens in the seminiferous tubules? Yeah, seminiferous tubules. So from the outside to the inside, you make your little sperm, right? And then they end up in the ejaculate, potentially. Okay, but where do you produce your testosterone and other androgens? In the cells between those. Those are either called interstitial cells or sometimes Sertoli cells. Leydig cells between. Does that make sense? Okay, I won't test you on the cell name, by the way. So between the seminiferous tubules is where you do androgen secretion. You with me? Okay, so what are androgens for and what are we talking about as androgens? What we're talking about as androgens is these guys that you keep seeing over and over again. Where are they? These are the androgens collectively, but the bottom three right here are the ones that primarily come from the testes. These two also come from the adrenal cortex, so there's a little bit of overlap there, yeah? The two super testosterone-y ones are these bottom two. Those have a really, really high affinity for the receptor, and they're only produced in high quantities in the testes, these two. Testosterone and dihydrotestosterone. Okay, DHT. Okay, so what do your androgens do for you in a male? So they do things at a couple of different times. First of all, I'm going to oversimplify the development of the reproductive anatomy, and I talk about it a ton in anatomy, but first of all, there was a time in which you didn't have a distinct anatomical sex. Before about 6 weeks post-implantation, you had the ductwork to become either. Yes? Okay. And then about 6 weeks post-implantation, what happened is the Y chromosome, if it existed, would start the production of things that would lead to ultimately testosterone secretion. And the testosterone secretion would make that clitoral structure turn into a penis, make the ovaries start to turn into testes, and eventually they would descend through the inguinal canal. Not that early, right? So they basically put the male junk like in order, right? Okay, so that's what testosterone does 6 to 9 weeks post-implantation. So no point in having a sonogram to figure out the sex of the baby before that because you ain't got one, right? You're just a baby. Okay, and then it's pretty much no testosterone to speak of until you hit puberty. And when puberty starts is when you start making GnRH, and then you start making your androgens. You with me? Okay, so what happens there is this. Okay, and we're going to draw this. You guys ready? Okay, so we're going to tell both the spermatogenesis story and the testosterone production story. Ready? And it's not bad, and you already know most of it. Okay, so if you are going to make androgens, including testosterone, where do you start? What hormone? Yeah, not what hormone, what place? Hypothalamus makes GnRH, which is, by the way, when puberty turns on. Okay, and GnRH, you know where it goes. Tell me where it goes. Anterior pituitary. Okay, goes the anterior pituitary. Got it? Anterior pituitary, in response, makes which hormone that is relevant to androgen secretion, testosterone secretion? Luteinizing hormone, yes, luteinizing hormone, that one, okay? And luteinizing hormone will go to the gonads, special cells in the gonad, the interstitial cells, whatever, you don't care. They did an anatomy class, okay? And then the gonads will respond by making androgens. Okay, and we know that too much testosterone can be a negative thing. Do we not know that? Yes. Okay, so how do you make sure that he doesn't go into a roid rage and he has normal levels of testosterone, guys? Feedback. Where do we feed back? We feed back definitely to the anterior pituitary, but what is special about me that I can also go? Hypothalamus, because I am lipid soluble, yes? Okay, so in a normal male without roid ragey problems, if testosterone level is supposed to be here, you just go up and down and up and down. Slightly more sex drive, maybe a little more pissy up there, slightly less here, right? Not dramatic, just like keeping it in a normal range, just like any other hormone, right? That make sense? Okay, so that tells the androgen production story. But we also have to acknowledge that testes don't just do androgen production, they also do spermatogenesis, yes? Okay, so the spermatogenesis story also starts here, but then what is the relevant hormone from the anterior pituitary to spermatogenesis? Yeah, it's FSH, which is follicle stimulating hormone. It goes to the gonads too. Specifically, it goes to the cells that are lining the seminiferous tubules, if you care. And what it will cause is spermatogenesis. Okay, but listen, only if you have androgens. So, which one precedes which one? Do you need testosterone before spermatogenesis, or do you need spermatogenesis before testosterone? Testosterone before spermatogenesis. So if you don't do that side, the other side is not going to happen. Is that okay? So, again, how does a male's body know when he has made enough sperm and he can chill on the sperm production? Boatloads of sperm are made every day, but not infinite quantities. So these do not swim back. Ain't nobody gave consent for that, did you? No. So what, instead of that, you make a hormone at the same time you do spermatogenesis, and the hormone is called inhibin, and it's a peptide. So it's going to feed back to where, because it's a peptide? Anterior pituitary. And it just inhibits FSH, guys. Does that make sense? So, a male makes some sperm, yeah? When a male ejaculates, it's usually 350 million to 500 million sperm per ejaculate. And then his inhibin level would be really, really low, right? Okay? Because he had not made any lately. And then he would make some more sperm. As soon as he made it, his inhibin level would come up and he'd stop making sperm. Right? That makes sense? Okay. So this happens over and over again. It will happen even if the male doesn't ejaculate, because all that happens is you make fresh ones all the time and you just reabsorb them if you don't use them. You make fresh ones all the time, reabsorb them if you don't use them. So it is not true that not ejaculating is going to cause cancer, for instance. And if you heard that, it was probably told to you by a male. And it doesn't happen. I'm not saying that it's comfortable. If you get close to ejaculation, it doesn't happen. It can be uncomfortable, but it's not going to cause long-term health effects, right? Otherwise, you would have a whole bunch of Mormon missionaries with testicular cancer and maybe some priests, right? But we don't see that, okay? That's assuming that that actually happened. Okay, so what does this do for you, okay? So what do your androgens do for you? In addition to causing secondary sex characteristics to develop in a male after puberty. That's all of the changes that you see going from like an 8-year-old boy to like a 16-year-old, 25-year-old boy, right? So you're going to have an increase in bone mass, especially in length, but also in width. You're going to have an increase in muscle mass, yeah? You're going to have axillary hair and pubic hair and facial hair develop, yeah? Thickening of the vocal cords and the thickening of the larynx, and then brain effects, right? So your brain is different at 15 than it is at age 8, in part because testosterone feeds back to the brain and it causes an increase, for instance, in sex drive and libido. So all of these things are going to happen. Because androgens cause you to build body mass, they are considered anabolic steroids, not catabolic steroids. That make sense? Okay, anabolic steroids. So the testes also produces 2 other hormones. Inhibin is one of them. The other one I didn't talk about in the other class. I probably won't test on it, but it's called Mullerian inhibiting hormone. Remember me telling you before that you started with both sets of ducts work? Okay. Mullerian inhibiting hormone is only made in males. It's encoded on the Y chromosome. And what it will do is when it turns on, it disintegrates the ducts that would have become female. Does that make sense? It's only on the Y chromosome. Okay. So you had both sets of ductwork. So you had ductwork that could have been the vas deferens and the seminal vesicles, and then you had ductwork that could have been ovaries and fallopian tubes. So MIH disintegrates the female ducts. Okay, so the question is, can you reconstruct this chain? And I hope the answer is yes. Okay, so can you reconstruct the chain that starts in the hypothalamus and ends up with androgens and sperm? Yeah? Okay, so disorders associated with this, or clinical stuff associated with this, sometimes people decide that they want some more testosterone even though they had just fine levels of testosterone. And so sometimes they start supplementing it, usually to build muscle mass. This one right here is weak sauce. You can buy it over the counter though, DHEA. Does it work? Maybe a little bit. It's a little hard in your liver and your kidneys to take it. Sometimes it doesn't cause much of what you want. If you really, really want to get swole, then people start supplementing with these. But they don't get it from a human. It's usually pig testosterone that they actually get. And it's most of the time they inject it, but not all the time. And so they inject this, and what they want to do is they want to get far above normal physiological levels of androgens so that they can get far more muscle mass. That's the thing that they want to do, right? So are there any potential negative effects? Well, hell yeah, because this thing is supposed to control the level in a feedback loop. So let's talk about what would happen. Okay, so I'm trying to get swole. I'm a dude trying to get swole, and I'm shooting myself up with anabolic steroids, right? And so what happens when you shoot yourself up with anabolic steroids is you're going to break your feedback loop. So let's see what happens. So I'm taking in tons of these over a long time, not a short time, right? And if I'm taking in tons of these over months to a year, 2 years, whatever, what's going to happen to my level of GnRH? Decrease. What's going to happen to my level of LH? Decrease. What's going to happen to my real human androgens? Decrease. What's going to happen to my level of FSH and my spermatogenesis? Decrease. So you can cause infertility by doing this. And in addition, because you're not really using your testes, they will shrink up. Here is testes, human testis, after long-term anabolic steroid use is on the right. Normal one is on the left. Okay, they shrink up to the size of English peas. Any other symptoms associated with it? Yeah, you're going to kind of be like a teenage boy, only pissier. You're going to have zits. Yeah? You're going to sweat like a pig. Okay? You are probably going to have acne. And you are probably going to be relatively aggressive with a pretty high sex drive and testes the size of English peas. Sounds super sexy, right? You're like, I totally want that. I want me a man like that. Okay, so in addition, it causes you to degenerate your bone mass. Oh, and one more thing. If you're not careful and you're not a smart roid rager, if you are a smart roid rager, you should also give yourself an estrogen antagonist unless you want boobs on top of your pectoral muscles. Because see what will happen right here if you take in a whole bunch of that? Yeah, you'll get breast development is what will happen. So that one's kind of an interesting one. So generally speaking, not a really well-considered plan, right? So you did it probably so you could get laid, and then eventually nobody wants to hang out with you, right? Okay, go ahead.
So is that something like seriously goes down on that? Is that something that can be reversed? Like,
we never know whether it can, and we never know how long it takes to cause sterility. Are there situations in which it was reversed? Absolutely. Can we guarantee that it will occur? Absolutely not. So you never know whether you broke it temporarily or broke it permanently when you break it. Okay, so the other thing, by the way, is precocial puberty. We know we learned it with the adrenal cortex. It can also happen if something happens on the testes, right? If they have a testicular tumor as a child, it could cause precocial puberty. And then one last one, and then I'll answer your question, Toby.
Oh, sorry, I was scratching.
Oh, okay. Androgen insensitivity, I teach this one in anatomy, but I just want to tell you briefly that if you are insensitive to androgens, what will happen is you will be XY, for instance, but not develop as a male. So this is a genetic disorder called androgen insensitivity or testosterone insensitivity. And what happens is you have an XY baby that is developing, but they're insensitive to androgens. And the default anatomical sex in humans is female, especially externally. So if during that 6 week that you're supposed to do sex differentiation, you're insensitive to androgens, then the external genitalia will look female, right? You're going to have a baby and you're going to name her Chelsea or whatever the hell you're going to name her, and you're going to raise her as a girl, right? And she's XY. She won't know she's XY. And then by the time she hits puberty, remember that excess androgens will get converted into estrogens if they're not used. So she'll start having breast development. She'll grow relatively tall. She'll hit puberty a little later because boys hit puberty a little later. But then she won't menstruate because she doesn't have a uterus. Everybody starts out with a blind vagina. All of us did, part of the ductwork. With males, it will close. Hers didn't close, but she also didn't complete the development of the internal reproductive structures of the female. She doesn't have a uterus. And her gonads started out up here, but they never really completely developed into ovaries, and they didn't completely develop into testes. So she's got a blind vagina, no uterus. She's got external anatomy that is female. And so she's pretty much female. And by the way, almost all the time they identify as female because we think that sex identification, gender identification, I don't want to get into the word gender because people go all bonkers about it. But happens because of the testosterone spike. They do think, by the way, that the default mental gender in humans is also female. So anyway, she is XY, but she is female. So I know that people like to argue about transgender situations, but I would like to tell you that this is a physiological example of a situation that resulted in something that could be considered transgender, right? Because she is XY with large quantities of testosterone, and yet, anatomically, she is female. And generally, what does she identify as? Female, right? Okay, go ahead.
Would they still develop the MIH?
No. Oh, they do have MIH. That's why the internal reproductive tract degenerates, right? The rest of it. Go ahead.
Does this differentiate between, hermaphrodites and?
Yeah, this is different. This is different. Hermaphrodite, if you want to talk to me about that, I can teach you. You already took anatomy now?
Yeah.
Okay, so hermaphrodites are usually XY, but like I said, you start out with both ductwork. If MIH doesn't work and you still start developing as a male, you'll usually have some male reproductive stuff and some female reproductive stuff. Most people who are hermaphrodites or pseudo-hermaphrodites, not all, most of them are XY because the differentiation into a male is like a secondary thing. It takes 2 switches to work to get a male anatomically normal. Okay, so anyway, you can argue about transgender all you want, but here's one physiological example of when it actually occurred and ended up with someone who was, for instance, at birth, named Chelsea, and test them in their XY and have high levels of testosterone, and then try to get her to use the other bathroom. Good luck with that. Okay, all right, so now let's talk about ovaries. Ovaries are the same anatomical structure, homologous anatomical structure to testes. And so let's talk about what estrogens do, and then we'll do the same feedback loop. So estrogens are, of course, not related to sex drive. Estrogens are these guys right here. The biggie is estradiol, but it's not the only one. And they are responsible for female development and then secondary sex characteristics. So the development anatomically, 6-7 weeks post-implantation, would be an XX fetus, does not have a Y chromosome, right? She will not produce MIH, so you will not have degeneration of those internal ducts. So she had the precursors to a uterus and fallopian tubes in there, right? If you spike her with estrogen at the right point in development, they will continue to develop, right? So, and then the male reproductive ducts will degenerate naturally. It's actually a female hormone that makes them degenerate. But basically, if you leave a baby alone, they will develop more female than male. They might not be reproductively functional later. So, female development. And then, again, estrogen doesn't do a damn thing until you hit puberty, and then GnRH turns on. And then it causes the development of the female secondary sex characteristics, including, of course, reproductive viability, breast development, increase in height, increase in muscle mass, but nowhere near as much as testosterone, right? Okay, so a bunch of things change. And then, of course, it feeds back to her brain as well. The brain after puberty is not the same in either sex. So in addition, estrogens are responsible for the female reproductive cycle, including oogenesis. And remember that estrogens are just converted androgens. So let's talk about this story, and then we'll talk about progesterone. Okay, so your estrogens, I'm going to simplify this a little bit, but I'll project it before I simplify it. Okay, so it's pretty much the same story, guys, because it's actually the same organ. So if you want to talk about estrogen and oogenesis development, you start where, of course? You start at the hypothalamus. And what's the relevant hormone? GnRH. Okay, where's it go? Anterior pituitary. And then the anterior pituitary produces which hormone relevant to estrogen secretion? LH. And it goes to specific cells in the ovaries. But let's just say ovaries for right now. And the ovaries respond by producing estrogens, a bunch of them. How do you know when you got enough estrogen? No, negative feedback. It's a steroid, feeds back to the anterior pituitary, feeds back to the hypothalamus. Now, it's far more long-term cyclical than males. It's like a 28-ish day cycle. It's not 28 in every woman. It's like anywhere from 21 to 36 or something like that. But this is far more cyclical over long periods of time than the male, but still it does the same thing. Okay, but we haven't made any eggs yet, so let's do the other part. If we want to end up with oogenesis, what's the relevant hormone? FSH. Goes to different cells in the same organ, and what it causes is oogenesis. Okay, but only if you have estrogen. Same story, right? Only if you have estrogen. How do you know when you just did oogenesis and you can chill for a few weeks till you start it again? What do you think? Inhibit. Yeah. So it's the same story. It feeds back to the anterior pituitary, inhibits FSH release. Of course, this happens far less frequently than that does, but it's the same story. Is that okay? Okay, go ahead.
So do the ovaries make estrogens directly, or do
they make androgens, and they have lots of conversion enzymes. That's why I said I was going to simplify it. This actually shows you it in a little bit more detail. The anterior pituitary goes to certain cells, and then you have enzymatic, and they make androgens, and then you make them into estrogens, right? But go ahead.
So, like, for example, when women might go to other countries and they stop menstruating for like months, like, why are they just not making estrogen?
I can't imagine that. Would it be stress?
That's what I've heard.
Probably cortisol. So when we talk about cortisol at the end, that would probably explain it, but I don't know for certain. But when we talk about the stress response at the end, it'll probably make some sense. Okay, so you actually always make androgens and then convert them. But you can just skip that step if you want. You know that estrogens are converted androgens, right? Okay, so let's talk about progesterone just briefly, okay? Progesterone has a complex release mechanism, so I'm just going to simplify it a little bit for you. Progesterone, estrogen causes progesterone to be released during certain portions of the cycle. So you don't have to do the feedback loop for progesterone. It's kind of complicated. So let me just tell you a little bit about progesterone. Here's what progesterone does. Progesterone is the ovaries telling the uterus what's about to happen, okay? So during a certain portion in the woman's cycle when she is about to ovulate, her progesterone level starts going up. And progesterone is progestation. So it talks to the uterus, yes? And what does it tell it? Get ready for a possible implantation, yeah? And how does the uterus get ready? Increases the endometrium, the lining of the uterus, right? And then it waits, right? Waits to see whether fertilization and implantation occurs. Fertilization, nobody knows when fertilization occurs, but fertilization occurs in the fallopian tubes, but it doesn't change anything about her chemistry. She can't even tell that it occurred. And then fertilization takes a few days, of course, to get down to the uterus. And then if implantation occurs, that's a pregnancy. And then it stays high if she stays pregnant. If implantation does not occur, either she hasn't had sex or implantation just didn't occur, then what happens is you wait, you go, not this month, and your progesterone level drops, and then she menstruates. Starts the whole damn thing over again, right? Does that make sense? So progesterone is progestation. As long as there is a possibility of implantation, your progesterone level is high. If you are pregnant, your progesterone level should stay high the whole time because it's progestation. Does that make sense? So progesterone is the ovaries talking to the uterus is what it is. That makes sense? Okay. Ovaries also produce inhibin. They produce one more little hormone that's kind of interesting, but only during childbirth. It's called relaxin, and relaxin does exactly that. During childbirth, you got to get a freaking watermelon through a nostril. It's really good if you relax all the connective tissues when you do that. So I didn't experience it. I couldn't go into labor because of my heart, but pregnant women, anybody experience it during pregnancy? It feels like if you throw a ball, your arm would go with it. You're like super floppy, right? When relaxin goes through, and it relaxes your pelvis so that you can get that baby out of there. Okay, so you should be able to reconstruct this chain. Now, one last thing we're going to talk about, and then we'll be done with the hormones, and that is clinical connections. RU486 is one of the, but not the only, drugs that you can use to block implantation. Okay, so let's talk about that. Oh, I always have to be careful about this in Utah, but I'm just not going to be careful. You guys know me, I'm not very careful yet. You ready? Okay, so RU486, which is also called mifepristone. I never can pronounce that without staring at the word. Okay, it's one of the many categories of drugs that can prevent an implantation. Note to self, physiologically, fertilization is not a pregnancy. As a matter of fact, 50% of fertilization events do not implant. So those of you who are mommies, in all likelihood, if you've got 2 kids, you have had, on average, 4 fertilization events. Some of them just don't stick. They're like, hey, and then they just get peed out. Not peed, with your pee. I mean, they don't come out through your urethra, but they just get flushed out, okay? So if you have had unprotected sex, a condom broke, you were sexually assaulted, whatever the reason, one of the things that you can do after that to prevent a pregnancy is take a progesterone antagonist. Yes? And what will the progesterone antagonist do? Yeah, it'll slough off the endometrial lining so that even if a fertilization occurred, it would not implant. Yes? That is most effective within, it depends on which one you take. Do you know? Plan B is up to 3 days.
And LLA is up to 5 days.
So 3 to 5 days. So it needs to be on, it really should be before implantation occurs. So why have these things become, I don't know, like a political football? So people call them the abortion drug, right? The morning after pill, the abortion drug, whatever. Because although it's not meant to do so, has one of these drugs ever, in the initial day or 2 of implantation, sloughed off an implantation? Yes, they have. Yeah. Can they do it 2 weeks in? No. Can they do it 10 weeks in? No, they totally can't. But your body has no idea whether an implantation has occurred, and you can take this to try to prevent an implantation. So from a physiological perspective, what they are meant to do is to prevent implantation, which, by the way, is how IUDs work as well. An IUD primarily does not prevent ovulation, it prevents implantation. Yes? the copper ones annoy the lining of the uterus so that it never actually thickens, but it doesn't prevent ovulation. What? And it makes it hostile to the sperm. And then the Mirena also has hormones that are released that just make the timing of ovulation and the thickening of the endometrium not timed properly, so that even if you ovulated, it couldn't implant. So anyway, so you can argue about that with your family if you want to, right? Go ahead.
Birth control progesterone antagonist as well?
Is birth control? No. Oral birth control?
Yeah.
What it primarily does is you really need a cycle that is exact timing of estrogen and exact timing of progesterone in order for ovulation and friendliness of the uterus to cause pregnancy. All it does is messes up the timing so that they're never together at the right time. And some birth controls are estrogen and progesterone, and some of them are progesterone only, but all they have to do is jack with the timing so that if you ovulated and fertilized, it wouldn't implant, right? So most of them try to prevent ovulation. They are not 100% about preventing ovulation, hence my son. but and probably like a bunch of you guys too. On average, half of pregnancies are unintended. But they work relatively well. They're supposed to prevent ovulation, and if they don't, they're supposed to make it so that it's not going to implant if you ovulate. Does that make sense? Okay, so these are now available over the counter. Yes, and we have a Planned Parenthood. She works at Planned Parenthood, so she can always tell us the most current information. And they're not cheap. What'd you say?
They're 50 at like anywhere else, but they're 30 at Planned Parenthood unless you're like an established patient that is based off your income.
Based off your income. And I think you have to be 18, right?
No.
Oh, you don't have to be 18 here in Utah? That's amazing. Okay, so you can argue about that and vote against me, whatever. I don't care. Whatever.
If you were taking anything like that, but then you ended up getting pregnant, but you didn't realize that you kept taking it and figured out that you were pregnant, does that affect baby?
It is not going to affect the baby except for sloughing it off. If the baby makes it through, it is going to develop normally. It does not cause cell division problems. Go ahead.
So there's only like pills or anything like this for women. There's nothing for like.
They have developed the first pill for men. It just came out of the first stages of clinical trials. Yes. No, the newest one. The next round of clinical trials was pretty effective with very few side effects. However, ladies, I would just double up, man. I'd be like, oh, yeah, how, you take it every day at the same time? Sometimes I don't see you brush your teeth until noon. I think I'm going to take mine too. So let's just no, just, not that I wouldn't trust you, but like I get pregnant. So yes, I would like for you to help with that, but I'm the one who would get pregnant. So I think it's a great plan. I would still like, yeah, and here's a condom. Just, just to make sure. Okay, these other organs I don't test over. They're just there because later on when you are taking patho, you might run into them. The only one that you've learned so far and should know is A and P. Okay, a couple of them we'll talk about later. Okay, so this part right here is just categorizing endocrine disorders. You ready? So it's no new disorders except for one. And that one I won't test you over. I just have it there because it made me crazy that it wasn't symmetrical without it. So there are 4 categories that your endocrine disorders could fit into. Hyposecretion. Yes? Hypersecretion. Yeah? Hypo responsiveness. Receptors not responding. Hyper responsiveness you haven't met yet. I've got one of those for you, but it's super hard to understand, so I won't test you over it. I just want it there because it drives me bonkers because there wasn't one there. Okay, so let's talk about some things. If you have an untreated hypersecretion disorder for a while, it will do what? Which of these? Downregulation. If you let it downregulate, then you're going to have a hypersecretion problem that also causes a hypo responsiveness problem. Does that make sense to you? Okay. If, however, you have an untreated hyposecretion problem for a long time, it will cause upregulation and Hypo responsiveness. So the message here is it behooves you to treat endocrine disorders early because otherwise it's going to be really hard to get the levels right after your receptors have been jacked up. Does that make sense? So go ahead.
Can they eventually go back to normal response?
They can, but nobody ever can predict how long your physiology would take to do that. You know what I mean? They just never know. Go ahead.
How does like daily taking of oral birth control not mess up all this long term?
It messes it up short term, but you're also doing the lowest levels that you can. You're not doing physiologically abnormal levels. You're doing physiologically almost normal levels, but just at the wrong timing.
Okay, so it's not causing.
It does cause a little downregulation, and sometimes women have fertility issues for a few months before it fixes itself. But it's not huge quantities of these levels. Go ahead.
When a lady has a hysterectomy, and they have to take estrogen supplements,
Mm-hmm.
what happens if they don't take those?
You will start having losing bone mass, losing muscle mass, losing your secondary sex characteristics associated with estrogen if you don't do that. Yeah,
Your body won't.
because you're not going to make enough of them. So once you start making estrogen, it maintains your secondary sex characteristics. You would have something that looked like you were going through menopause. You would start changing your body fat deposition. Your characteristics can start to change with low levels of estrogen. Okay, so what do you think is easier to treat? You guys told me last time, hypersecretion or hyposecretion disorders? Hyposecretion are easier to treat. If it is a lipid-soluble hyposecretion, you have a lot of possibilities for treating. Oral supplements like Synthroid, estrogen pills, progesterone pills, those kinds of things, patches, pellets that you can inject, all of those kinds of things are possible. If it's lipid-soluble, you've got a lot of possibilities for adding it back. You can still do injections, but you don't have to. And then if it is water-soluble, you have fewer possibilities, but the fewest possibilities are if it's a peptide hormone. Can you take oral peptide supplements? Only if you want really expensive amino acid supplements, right? That's all you're going to get, right? So generally peptides like insulin and growth hormone have to be injected. Does that make sense? Because they have to bypass the digestive tract in order to get into your bloodstream intact. Now, what about treatment for hypersecretion disorders? Hypersecretion disorders are harder to treat. What do? If an antagonist exists, and they don't exist for all hormones, you could use an antagonist, yeah? Like an estrogen antagonist that we talked about before. If the antagonist doesn't exist, you can decide to live with it. You could do radiation, you could do surgery. There's not a whole hell of a lot, really, as far as hypersecretion disorders. So now let's talk about the categories of hypo and hypersecretion. You guys ready? This is just a logic thing. You have to listen. Ready? Okay, so let's do it with thyroid hormone. You guys work me through T3 and T4 secretion. Where do I start? I start at the hypothalamus. What hormone? TRH goes where? Makes what? Goes where? Makes what? Okay. And then the feedback mechanism, lipid soluble, so it goes both places. By the way, it's called long loop negative feedback if it goes all the way to the hypothalamus. Okay, now, can we agree that if you had a hyposecretion disorder, it could occur? Hyposecretion of this could be caused here, yeah, or here, or here. How do you tell? How do you tell where the problem is? You measure your hormone levels, okay? So there are names for each of these types of disorders. If it occurs here, right next to the symptoms, right next to the levels of hormones that you were looking, right at the end of the chain, it's called a primary hyposecretion. Yes? Primary, okay? And that would mean that you had what levels of this? Primary hyposecretion. Low. Well, what levels of these would you have?
High.
Yeah, normal to high, depending on how long you've had it, right? Normal to high. So everybody okay with that? These two? Yes? That tells you where the problem occurs, and it occurred here. Okay? If there were a secondary hyposecretion disorder, start at the top, move up, right? 1, 2. Okay. If it were a secondary hyposecretion disorder, This would be low. What would this be? Low. And the problem would be where? Anterior pituitary. What would this one be?
Still high.
Still high. Yeah? If it were a tertiary hyposecretion disorder, they wouldn't even care and they wouldn't treat it, right? Because they can't really get anything up there, but let's just say that it was, right? If it were tertiary, the problem would have occurred at the hypothalamus. Tell me about the levels of all three.
Low.
Low, low, low. Yeah? So where do you start? Primary, secondary, and tertiary. Start at the bottom. If you only got one, it's primary. If you got two, secondary. If you got three, it's tertiary. Yeah? And you treat them differently, by the way, even though you don't usually care about this one. If this was a secondary hyposecretion disorder, first of all, they'd know to look for other anterior pituitary problems. And second, they usually treat with TSH and T3 and T4 to get the system working a little better. Okay, so primary hyposecretions are really common. They can be either genetic, autoimmune, or maybe something's missing. Like this could be a primary hyposecretion disorder if this was primary. If I just was missing iodine, wouldn't that cause primary hyposecretion of T3 and T4?
Yeah.
Right? It's just primary. It's just only occurring there. So that one's right there, right? The dietary deficiency, iodine deficiency, could cause a hyposecretion of T3 and T4. Let's talk about some autoimmune primary ones. Addison's disease is primary adrenal insufficiency. It's a hyposecretion of two adrenal cortex hormones. Do you remember them? Cortisol and aldosterone. Yeah. This is usually autoimmune. Usually this one is after an exposure to tuberculosis. For some reason, those antibodies that you produced in response to tuberculosis like to attack your adrenal cortex. They are relatively sure that that's how JFK got it. Got exposed to TB, and I think he was in the Korean War, but literally whenever I talk about history, assume that I don't know what the hell I'm talking about because I don't. But I'm pretty sure it was Korea. Okay. So type 1 diabetes mellitus is a hyposecretion of what? Insulin. And it's usually genetic / autoimmune, right? A little combination of the two of them. Hashimoto's disease, who remembers that one? Hyposecretion of T3 and T4, and it's usually autoimmune. Got it? Okay, so secondary hyposecretions exist. Tertiary hyposecretions exist. They all exist. Okay? Now let's talk about hypersecretions. So let's just do one example with primary, secondary, and tertiary hypersecretions here. Yeah.
So with I'm just spitballing, trying to understand. So Addison's disease. So if you said primary Addison's disease?
It usually is. It's called primary adrenal insufficiency.
Okay, so there's if it's secondary, they would say secondary.
Yeah.
Okay.
Okay. So let's talk about hypersecretions for just a second to make sure that you guys get it. Let's use thyroid again as an example. So if you have a hypersecretion, again, can you imagine that it could be here, here, or here? Hypersecretion, yes? Okay. So if it were a primary hypersecretion, the problem would be here, and the level of T3 and T4 would be high. What about the level of TRH and TSH? Low, low. Yes? Okay. If it were a secondary hypersecretion, the problem would be here. What about your level of TSH? High. Yeah? High. What about this one? Low. If it were tertiary, the problem's at the hypothalamus, overstimulating the other two, and it would be high, high, high. Yeah? That's how they figure out where the problem is going on. Does that make sense? Okay, so you can have primary, secondary, and tertiary there. How the hell would you know? Well, I'd have to give you hormone levels in the question, right? I'd say the person has all of these symptoms that would like maybe tell you that it was hypo or hyperthyroidism, and their levels of T3, T4, TRH, and TSH measure this, right? Not numbers, but just high and low. And you go, oh, okay, I got it, right? You can't know primary, secondary, and tertiary if I don't give you any of the information. Okay, good? Okay, so as far as hypersecretions go, primary hypersecretions can be caused by a tumor, although we do have one example of a hypersecretion that was caused by an autoimmune disorder. Do you remember? The autoimmune hyperthyroidism. Yeah, Graves' disease, when it's like a TSH agonist. That's the only one that I know of that's an autoimmune hyperthyroidism. You should be able to do these two. These hypersecretions are acromegaly and gigantism, both caused by hypersecretion of what? Growth hormone, exactly. And secondary and tertiary ones do exist too. Okay? All right. Hyporesponsiveness. So hyporesponsiveness is when the problem is really with the receptor or the signal transduction mechanism. Like the level of hormone might be fine, but the cell's not responding to it in the way that you expect it to be. So too few receptors and sensitive receptors, hormones present but not active metabolically, or signal transduction pathway. Usually I think about it as receptors. So T2DM, type 2 diabetes mellitus. You should be able to do this one. This is a hyporesponsiveness of what? Insulin receptors, and it's often a response of what regulation? Down regulation. Good. Testosterone insensitivity, also called androgen insensitivity. Your level of androgens are fine, but you're not responding to them. This is a hyporesponsiveness of what receptors? Testosterone or androgen, I don't care which one you use. That's genetic. And obviously it can't be inherited. It's a mutation every time. They're not reproductively viable, the people with androgen insensitivity. They are female, usually identify as female, but they don't have a uterus, and their ovaries don't function all the way. So can't pass it down. Okay? All right. Hyper-responsiveness. I will not ask you about this one, but I'm just going to tell you because it makes me crazy when it's not symmetrical. Thyroid hormone is a metabolic hormone, but epinephrine also has metabolic effects, right? It dumps nutrients into your bloodstream. Yeah, remember? Okay, so if you don't treat hyperthyroidism over a really long period of time, it tends to upregulate your epireceptors. And so people with Graves' disease, if a tiger walks into the room, their heart goes through the roof. And it takes a really long time for them to settle down. Just those two end up causing upregulation in each other. But I won't ask you about that one. It's like hard to make it into a good story. But there's one, hyperresponsiveness. I don't know of any others, honestly. Okay, so inputs that control hormone secretion is our last thing to do. But this is not new material. All this is the hormones that you have learned, can you figure out their regulatory mechanism? So you can, I promise. Okay, so here's the truth. Hormones are not released willy-nilly. They're released in homeostatic amounts, and they have feedback loops almost always, right? So my question to you is, which ones use hormones for feedback? Yeah, this one uses a hormone that's actually feeding back. Like, what is going back through the bloodstream? Some of them don't use hormones for feedback. Can you think of any of them that use nutrients or ions to feed back? Not cortisol. Nope. Nutrients or ions. What? Calcitonin uses what to feed back? And then something else uses a nutrient. The sexiest of all the nutrients feeds back. No? Glucose feeds back. So you need to know how they fit. So they're either categorized three ways, right? It's either a hormone that feeds back. That's called hormonal control. Yeah? It's a nutrient or ion that feeds back, not a hormone, right? That's called humoral control, as in the humors of the body, but nutrients or ion are feeding back. Or it's nervous system feeding back, which is hard to imagine, but with epi, right? If you release epi because there's a tiger in the room, what makes you stop releasing epi? No tiger. If you release oxytocin because you're cuddling, what makes you stop releasing oxytocin? Right. That's a harder feedback loop to draw, but those are neural feedback loops, right? Nervous system stimulation changes, okay? So all we really have to do is categorize the ones that we know, and it's pretty easy. You ready? Okay. So you use negative feedback, but the question again is, what is feeding back? What is feeding back? Is it a hormone? Is it something else? So some things use nutrients or ions to feed back, and I know that you know that insulin does that. Yeah? It's not insulin that is the thing that is feeding back to stop insulin secretion, right? It is glucose levels. That, of course, means that glucagon fits in here too, right? Insulin, glucagon. What were the calcium ones? Calcitonin and parathyroid use calcium to feed back, yes? Okay, and then there's one more. I won't ask you about this one, but we're going to run into it later. The primary feedback mechanism for aldosterone is actually potassium, but we're going to talk about aldosterone in more detail when we get to urinary system. It's actually got like 4 different feedback mechanisms, so I don't want to like complicate shit now. I mean stuff. Okay. Sorry, video. Huh? Whatever. Okay. All right. So the other ones are these guys. So control of hormones by other hormones. Ta-da! Like that's one in which the hormone feeds back, isn't it? These are both ones in which the hormone feeds back. Yeah? Cortisol is one in which the hormone feeds back. Yes? Like there are boatloads of them in which it's the hormone that's feeding back to stop the hormone secretion. Go ahead.
Is there any of them that don't go back to the hypothalamus?
Oh yeah, anything that's not lipid soluble doesn't go back to the hypothalamus. Remember, although you don't have to draw this one, GHRH causes growth hormone to be released. GHIH causes it to be inhibited, right? So those don't go back to the hypothalamus. So does that make sense? Okay. So almost all of the 3 hormone sequences that start with the hypothalamus are like hormonal feedback. So T3, T4, sex hormones, a bunch of them. Okay. So last little tidbit before we get into the nervous system control, which is the last one, and I like this one, is, okay, so the hypothalamus is all up in everybody's business. We see that, right? Okay. Hypothalamus has got its fingers in like half of the endocrine pies. So if the hypothalamus is controlling everything, what's controlling the hypothalamus? And can you imagine, the hypothalamus has obviously nervous system function because it's gathering information about light and metabolism and temperature, but it also has receptors for a whole bunch of hormones. Do you see it has to? So what the hypothalamus really is, guys, is the crossroads between the endocrine system and the nervous system. Yeah? It gathers all of that information and synthesizes it to figure out what is necessary for your body, right? It is where it all comes together, right? It's taking in input sensation. It's also taking in input hormonal. It is really, really powerful about regulating your entire endocrine system and half of your metabolism, right? Because it has receptors for endocrine, for hormones, and it has tons and tons of nervous system activity as well. Have you ever seen how many nuclei are actually in the hypothalamus? There's like 14 different individual nuclei in the hypothalamus, all with separate functions. Go ahead.
So, like, I don't know if this happens, but can you, like, damage your hypothalamus?
If you get a hypothalamus tumor, you are basically going to be like somebody is scrambling all of your metabolism, almost all of your hormones. Everything goes wrong.
What are you, like, can't do anything?
No, it starts screwing with all of these hormones, right? All simultaneously. The one that can kill you is if you over or under secrete cortisol. That'll usually be the first thing that they notice. And then you'll have major metabolic changes, major sleep changes, all of those kinds of things. A lot of times hypothalamus hormones are a little difficult to survive. You can imagine. Go ahead.
So the different nuclei, I'm just going to spit this idea out there.
Okay.
Are those like basal cells in a way?
Basal
So you know
cells?
how like base cells, these are the normal cells where if something comes up, it takes something in, says, oh, that's not right, and then secretes everything out that way. Does that make sense?
No.
Because it says there's like resting membrane potential. Let's say that one. So resting membrane potential is 70, right? Negative 70.
In some cells, yeah.
Right? In some cells. Say that cell is up in the hypothalamus, and something disrupts that. The hypothalamus thinks I need to fix this, and then fixes that cell while fixing others. Is that something it does?
No.
I'd have to come back after.
No. You can come talk to me in my office, and we can talk about it. Okay, so let's get to the last part of the story, and I'm going to keep you late if necessary to do this. You can leave if you want to, but I'm not going to. So the last one is control of the hormone secretion by the nervous system. Okay, so simple examples. Why do you release oxytocin? Cuddles, right? Breastfeeding, orgasm, right? Sensation causes it to be released. Lack of sensation causes you to stop. Righty release, ADH. Well, primarily because the hypothalamus detects a change in osmolarity of the blood. If you fix it, it will stop secreting that. But it's still nervous. It's a sensory. It's actually a chemoreceptor in the hypothalamus. Okay. So those two are simple examples. Now let's get to the interesting but longer example. You ready? Okay. So your response to stress starts out, of course, nervous, but doesn't it quite often end up endocrine? Tiger in the room starts out nervous, but ends up endocrine? Yeah? If it takes you more than a minute to get away from the tiger? Okay. So the hormonal stress response is called, I don't know why the hell they named it this, the general adaptation syndrome. That's what they call it. And there are several steps. The first step involves epinephrine. The later steps involve cortisol and aldosterone. You with me so far? Okay, so we're looking at the hormonal aspect. We have to acknowledge, of course, that there's a nervous system aspect that is occurring, but we're not going to concentrate on that right now. We're not going to concentrate on what your brain is doing, all right? So this is the hormonal response to stress. So first off, we have to broaden our definition of stress to include things that are physical stresses in addition to things that are mental stresses, and realize that we evolved a single category of stress response regardless of whether it's a bad job interview or your arm just got cut off. Doesn't make any difference. You still have the same stress response, okay? So nervous system identifies or perceives a stressful situation. Broad definitions of stress: too much hot, too cold, infection, injury, strong emotion, starvation, alarming stimulus, emotionally charged event, either positive or negative, both causes the stress response. You could be super attracted to someone could be completely repulsive. They would both cause the stress response. So energy deficiency, lack of sleep, those will all initiate a stress response. But it is not stress if you do not perceive it as stressful. So somebody holds a gun on me, maybe I do not have a massive stress response. Somebody holds a gun on a cop in Compton, no, maybe I do, and they don't, right? It has stress perception, which has something to do with like what your prior experience is. In addition, the perception, it doesn't even matter if the stress is actually real. I have had anxiety attacks. Has anybody else had an anxiety attack? Does there actually have to be a tiger anywhere near you? No, there can be absolutely no trigger. Does that mean that the physiology in my body does not occur? It absolutely does occur. It causes a physiological stress response, whether or not there is an actual tiger, okay? So not all stress is negative, but it's all a disturbance of homeostasis at the moment. So you are stressed when you're in front of somebody that you're super duper attracted to, especially when it's like first, right? But it's not necessarily negative. If you like roller coasters, that's stress, but it's what we call eustress. It's stress that you seek out. It's transient. You picked it. You know when it's going to start. You know when it's going to end. Still stressful, but does not cause a negative response. But let's say that we are dealing with stresses. The first stage of the stress response, the endocrine stress response, is going to be called the alarm phase. Primarily involves epinephrine. Threat or stressor is identified, realized, conceptualized, whatever. The body starts to respond. The perception is important. If you can change the perception of something that is stressful for you, you might be able to change the response. Anybody else who's crazy like me may have had cognitive behavioral therapy in which your therapist talks through what's the worst that could happen in the situation, and then you figure out you're not going to die, and then it's slightly less stressful for you the next time, right? So the perception can actually change the physiology. Okay, so let's see what's going to happen. The sympathetic neurons are going to do what you expect them to. They're going to send an impulse to the adrenal medulla, and you're going to dump epi, a little bit of norepi, and some dopamine into the bloodstream. What's going to happen? Go to the target cells, dilate the bronchioles, make the heart rate go up. But remember, it also has metabolic effects, dumps sugars and nutrients into the bloodstream, right? Does that. Increases the metabolic activity of your skeletal muscles and cellular respiration in your skeletal muscles. That's great if it's a tiger. Not super helpful if it's a job interview, right? Not super helpful. So the result of the alarm phase: increased muscle tone, increased blood pressure due to vasoconstriction, increased heart rate, increased nutrients in the bloodstream. If it was a tiger, it helped you cope with the emergency. Is it negative? No, if there were a lion or a tiger, all of that crap was super helpful, especially if you didn't die, right? If it happens repetitively, however, it can cause changes that are not positive. You will deplete your glycogen stores, for instance, yeah? You will have slightly elevated blood pressure, you will be hard on your cardiovascular system, and it can lead to atherosclerosis and that kind of stuff. Now, how can you counteract the effect of those changes if, for instance, you're a cop or a firefighter? You keep your cardiovascular system in really, really good shape, right? You exercise, you keep your blood pressure as low as you can, you eat well, those kinds of things, and you can counteract the effect of those. And of course, training makes it less stressful, right? If you're more prepared, it's less stressful. Okay, so when the stress is removed or overcome, no more neurons firing. You can also change your perception of the stress if you need to. Okay, so now we get into the next phase. In the next phase, there is nothing trying to kill you right now, but you might live in a situation in which you don't have adequate amounts to eat. You might live in Yemen, right, in which your house isn't being bombed at the moment, but it certainly could be within a moment's notice. You might live in an abusive relationship. This is long-term, low-level stress. And then we come back to this picture that we've seen before. And this picture that we've seen before is our cortisol picture. Only this time the trigger we're going to focus on is this one. Yes? This stress, right? Okay, so long-term low-level stress causes you to secrete cortisol. Please remember that cortisol is a really protective friend, but it's a super-duper pessimist, right? It's not sure things are ever going to get better, but it's trying to protect you in the moment, okay? So chronic stress will make you secrete more CRH, more ACTH, and ultimately more cortisol, so keep that in mind. And so cortisol's objective is survival until things get better, but it's pretty sure things are not going to get better, right? So it's like a friend when you're in need, during sleep or sickness or starvation, but if it overstays its welcome, it's going to eat up all your crap and damage your house is what it's going to do, right? So you never want your best friends to stay for very long because they will not end up being your best friends. This is cortisol. So let's see what happens. Long-term effects of even slight but chronic oversecretion of cortisol. It is going to gradually deplete your resources. Gluconeogenesis starts in the liver, but remind me where you get the proteins to do gluconeogenesis. Skeletal muscle and bones. You start to eat up your skeletal muscle with long-term stress. Tears your body apart literally. And remember, it depresses all of your non-essential tissues. So decreases glucose uptake and metabolism in all non-essential tissues. Decreases growth, repair, reproduction. You have an increase in miscarriages. You have an increase in erectile dysfunction. You have reduced fertility. Does that make sense? So maybe that has to do with what you asked. Yeah? The net reduction in metabolism depends on, may make you gain weight or lose weight. It really depends on whether nutrients are readily available. In the United States, the net reduction in metabolism will cause weight gain because we have adequate nutrients, yeah? In other situations, you can have weight loss, right? In which we really depress your metabolism. We also depress your appetite and you didn't have a lot of access to nutrients anyway. And then chronically circulating high levels of glucose will increase your risk for type 2 diabetes mellitus. So type 2 diabetes mellitus, guys, is actually more common in people who are poverty-stricken than it is in people who are not. That stress increases the likelihood that you are going to dump excess sugars into your bloodstream. Okay, now, other impacts of cortisol secretion. It inhibits your immune system. Why does that matter? You can get opportunistic infections that you wouldn't get if you weren't stressed out. It decreases antibodies, decreases T cells. Everybody got exposed to some weird thing of bird flu, and like, who gets it? The person who's super stressed out, right? Because it decreases your immune resistance. Lowers your resistance to disease and cancers, slows healing once you get things. The vessel effect is that it keeps your vessels slightly constricted, but remember that you're going to be out of it when you need it. You're going to secrete so much cortisol that you don't have it when you need it. So keep that in mind for just a second. And then this is the new research that I find super fascinating. And it's not in your textbook, and they've only known about it for about the last 4 or 5 years. The brain effects of chronic cortisol secretion are consistent with the rest of the effects, and they are this. It will increase the activity of anything in your brain that it thinks will get you through this emergency and decrease activity of things that were more long-term. So what we see in the brain activity of people with chronic cortisol secretion is it reduces memory formation. Remember, it's a pessimist. We don't really need to remember a whole hell of a lot, right? It increases the activity, the size, and the blood flow of the amygdala. And the amygdala is about vigilance, right? You are looking around to see what the hell is going to attack you next. And then the important thing, it also decreases activity and even mass in the prefrontal cortex, which is all about long-term decision-making, planning, being able to put off the immediate for the long-term goal. Does that make sense to you? Have you ever made really crap decisions when you're super, super stressed out? No, you haven't? Okay, well then we would not be friends. That's all I'm saying. Okay, so the thing I want you to think about when you are looking at that is the impact on children, of chronic stress on children. And then think about the next part. Stomach and intestinal ulcers increase because you decrease your resistance to Helicobacter pylori when you depress your immune system. And then remember that if you mess with your cortisol, you also mess with your aldosterone. So the long-term effects are you're going to retain sodium. What will that do to your blood pressure? Increase it. You are also going to dump potassium, which can lead to hypokalemia and cardiac arrhythmias. Yes? Okay, so the net hormonal effect of chronic stress now is an anxious, sleepless person with high blood pressure, very few energy reserves, higher probability of cancer, higher probability of ulcers, catches every damn weird germ that comes around, higher risk of myocardial infarction, higher risk of type 2 diabetes, decreased mental coping and decision-making skills. And the question that I want to ask you is, does this mean that my middle-class, relatively privileged child could be put in an environment, right, with a kid who was from poverty, from anything that caused long-term cortisol secretion, a kid of the same intellectual level, and we put them in the same class? Can we physiologically expect the same kinds of behavior and performance from those two children? Is it reasonable to do so? Is it reasonable to assume that if you change just the environment after decades of high levels of cortisol, that that alone will fix it? Does that make sense? So in this situation, it becomes a public health issue and something that we can probably think about better as a society. Okay, all right. Next two stages and then we're done. Two possibilities. Hey, you stop being stressed out. This stops. And it kept you alive. Cool. It was a friend when I was in need. Thanks, cortisol. You used up all my crap, but I survived, and now I'm going to replenish my crap, right? It was effective, okay? The stage of exhaustion is what can happen if that does not occur. The stage of exhaustion is, why do people who are chronically stressed die? Opportunistic infections, complications of diabetes, cancer, shock. Because if you get hit by a car but you've depleted your cortisol, you won't be able to constrict when you need to. Remember, it's supposed to cause you to do that. Hypokalemia leading to cardiac arrhythmias and myocardial infarction. Okay, last little bit. What's the good news? Is there anything that can help? Well, you already know some of it, right? Reduce your cortisol by don't be stressed out. Just don't be stressed out. How about that? Is that helpful? Okay, reduce your cortisol by the usual suspects. Reduce your stress. Good diet, exercise, sleep. Other mechanisms that exist, preparation for whatever you are about to encounter reduces cortisol secretion when you encounter it. Yes, exactly. Reduce your perception of stress. Cognitive behavioral therapy, going through what's the worst that could happen with someone who actually has the mental capacity to tell you that you are not going to end up homeless, crack hoe if you fail this test, right? That is not the next outcome, right? That's what my therapist has to talk to me about. She's like, you've got some degrees, you'll be fine, it'll be fine. I'm like, really? Okay. Gaining control over your environment is really important. Have any of you guys feel better when like everything feels like it's going to hell and then you like do your laundry and fold your stuff and make a spreadsheet? And you're like, what?
You do the dishes?
You do dishes, yeah. Friendship and support, all of those reduce cortisol. I'll tell you one other little thing. I know you guys are getting restless, but I'll tell you one bad thing. You want to hear one bad thing that reduces cortisol that the research shows? Okay, put a rat in a cage, shock the rat, its cortisol level goes up. Shock the rat, its cortisol level goes up. Give him a friend that he really likes to cuddle, and his cortisol level will go down. That's great. Give him his enemy, and he will just go bite the crap out of him afterward, and then his cortisol level goes down. So don't do that, but I'm just telling you the truth. Okay, the last thing is that if you can increase oxytocin, it decreases the effect of cortisol. Oxytocin causes vasodilation, which drops your blood pressure. Oxytocin is actually the only thing we've ever found that can repair damaged cardiac muscle from long-term cardiovascular damage. It decreases inflammation. It increases trust. How do you get more oxytocin? Welcome physical contact, totally. Welcome physical contact, only if it's welcome. Play with your kids, play with your pets. Dogs are better than cats, we all know it. Friendship and human connections and sex. All of those, as long as it is consensual, right? That's the only kind that's a good kind. Okay, so I will see you guys on Monday.